So for those of you who have a mute button, please use. For those of you who don't have a mute button, we can hear everything. I just want to try and eliminate as much background noise as possible so that it doesn't disrupt the recording for people who need to get on at a later date and time to review it. So let's see here. Can everybody, just real fast, like I just want to make sure this goes off without a hitch. Can you guys see my slides okay, like the very first slide up on your screen?
Yes.
Okay, thank you very much for that. And everybody can hear me okay?
Yes, I can.
Oh, all right, thank you. I appreciate the feedback. Okay, so with that being said, we're going to get started. And a couple of things. You guys are going to be my guinea pigs. I'm fairly new with the ReadyTalk system. It's been great so far, but I did some polling that I'm going to be doing in this because the one thing I noticed when we did the ED Transfer 6 presentation a couple weeks ago, I should say last month, is I wanted to try and make it more interactive. And I know sometimes people aren't as prone to talking during webinars and asking questions, or if I ask questions to the group, getting somebody to come forward and actually, give their feedback or their opinion. So I built in some polling questions, and I'm hoping they're going to work. If not, then I might just skip over them and or ask the group the questions directly and see if I can't get any feedback from you guys that way. So bear with me as you guys are my guinea pigs for this. So let's see. I'm going to go over the agenda for today's call. If it'll, let me change slides. Okay, so we're just going to go over the ED transfer measure 4. We're going to kind of just go over an overview. I'm going to just show some data, which again, this is a 3-state webinar series. I know I didn't mention that earlier, which I should have. It's Iowa, California, and Wyoming that are kind of doing this together.
Shanelle, it's Illinois. Shanelle,
oh, Illinois. Sorry.
Illinois. Okay.
Thank you, Michelle. Illinois, I'm sorry. The Flex Gals, which Michelle, you just heard speak, they got together and kind of thought that this would be something that would be beneficial to the critical access hospitals in their state participating in the Medicare Beneficiary Quality Improvement Project or program, MVQIP. So we're kind of splitting up the roles and the responsibilities. So Wyoming's kind of handling the ED transfer webinar series and quality improvement piece. And then, and I know I'm going to group this up, I think it was California that is handling the NHSN, well, I should say the web-based measure portion. So it was the immunization measure and the healthcare personnel influenza vaccination measure, which was like OP27, and those were the newest measures to MVQIP. And then I cannot remember what the other one is, Michelle. Was there another topic?
Well, Illinois we're working on the IMM and OP27, so that will be a conjunction between all 3 states, but Illinois is going to be leading that charge. But we'll just go on to the ED4 and we'll make it good for now.
Okay, so just stay tuned for that information. Anyway, so we're going to go over a little bit, and the reason why I was kind of just jumping into that is because it is multiple states. The one thing that I lack is the ability to see the other states' data. So I kind of use Wyoming aggregate data, since that's the data we have access to kind of give us an idea of how we're doing on certain measures so that we have, I should say more of a picture of where we're doing with each measure in terms of, okay, where are our best performing measures or where are the measures where we could use a little bit of improvement. And that's how we're kind of coming up with the measures that we've come up with so far across the state to focus on. I'm going to go over a little bit of the abstraction guidelines because it was brought to my attention the last data submission for ED transfer. There was clarification needed on the abstraction guidelines, so I'm just going to touch on that briefly. And then I'm going to show you how to use your ED transfer report within the ED transfer data collection tool to look at your facility's individual results and use it for improvement in your facility, specific to your facility. And then I'm going to do a little bit of sharing of best practices. The one thing that I've been trying to do, and again, not really knowing, well, hoping to get to know other facilities a little bit better in other states, is trying to get like a couple facilities to share how they're doing in their facility on a particular measure or just the ED transfer measures as a whole. So I did have a facility share some information with me, and that's going to be a couple of slides worth of the information that they were sharing that they were willing to share with the group. Unfortunately, they couldn't be on the call, so I had a call with them this morning to kind of go over it. So I will try my best to interpret what they have shared. And then we're going to touch on the PDSA, and then if there's time allowing, I want to go into some sample forms and checklists and fact sheets. We did this on the last webinar as well, but I have some new ones specific to the ED transfer for Measure, and then of course all of the ED measures for like the transfer form itself. And then we'll just kind of wrap up from there and see if there's time we can open up for questions. And at any time when I'm on any slide, I want to keep this informal. If you have questions or comments or whatever, feel free to interrupt. I don't want to get too off course, so I'll keep track of the time. But I just, like I said, I want to keep this informal. I don't want you to have to hold your questions to the end, especially if we're in the middle of the presentation and you have one. Let's see here. Slides are a little slow. Okay, so for today, for the purpose of ED Measure-4, we are going to be looking at the medication information, and there are 3 data elements that are a part of the ED Measure-4, which are medications given, allergies, and then medications from home. So those are the 3 focal points of, or the data elements that encompass and make up the ED Transfer 4 measure. And here is the data that, let's see here. Okay, so I update on the last webinar. I actually showed the most current quarter we had was 4th quarter 2015, and now this webinar we actually had 1st quarter available. And this is just aggregated results. And you can see actually for the last 2 quarters, I should say 3rd quarter and 4th quarter, we actually had a dip in our results, which is one of the reasons why we decided to focus on the ED Measure-4. But this current quarter that just passed, which is 1st quarter, we had a bump up. And the reason for that being is that we had higher participation from the facilities than we had in the past. And so I just wanted to point that out. So it's still a focus, and I think until we can prove and or sustain our rates, it's something that we should continue to work at to make sure that they don't drop again. But if you see here, the last 2 quarters that we based this off of, which is 3rd and 4th quarter, they were in the low to mid 70s, which is, again, why the focus. And actually, if I switch to the next slide, there we go, you can see it a little bit better because it's not as busy with all the other quarters worth of results. So it's just the primary the last 3 quarters, which are highlighted here for the ED measure for medication information. I'm going to take a minute just to ask, and I ask this on every webinar. I was just wondering, is there anybody who would be willing just to chime in for a quick second and give their thoughts and or comments as to why they think ED Measure-4 medication information is one of the measures that's focused across the 3 states as a measure that's needing improvement? Does anybody have any theories to that, or at least want to share why they think it is the case in their facility?
Hi, Shanelle. It's Amber from Sundance. How are you?
I'm good, thank you. How are you, Amber?
Good. I think the biggest reason this is getting missed is just, well, I think a lot of people share our EMR problems, and they're just not getting recorded.
So it's a documentation issue and or possible staff education issue with the implementation of a new EHR?
Exactly.
Awesome. Okay. Yes, that's kind of what we got on the last webinar with ED Measure-6 as well. Thank you for sharing, Amber. Does anybody else have any thoughts outside of what Amber just shared? Or does that kind of seem to be the consistent thing? All right, well, we'll just move on. I appreciate you sharing. So since there's not going to be a whole lot of discussion, this is where the fun comes in, and let's see if I can get it to work. Oh. Okay, so on your screen there should be a survey. And I'm going to time it for, I'm just going to take like a couple minutes, and I want everybody, if you can see it. Well, first of all, can you see the survey up on your screen?
Yes.
Okay, I would like for everybody who is on the webinar portion to answer one of those. The question is, out of the 3 data elements for the ED transfer Measure-4, which data element do you feel your facility struggles with the most? It could be an all or nothing, but if you have one in particular, you can skip it. But I would rather try and get feedback because, and while you guys are answering that, I'm going to actually go into a little spiel here. Similar to, I'm trying, in comparison to like measures that you guys are most familiar with, like the CMS core measures, particularly like the inpatient core measures since they've been around forever. It kind of reminds, all of the ED transfer measures kind of remind me of like the heart failure inpatient core measure, particularly the discharge instruction. And the reason being is that it's kind of like an all or nothing. So for each ED transfer measure, such as ED transfer Measure-4, there are 3 data elements that you have to comply with in order to meet the criteria for that measure, which means it's an all or nothing. So if when you're completing and abstracting a patient for this particular project, if you do not do all 3 of these, then it's automatically like a 0 in your numerator and a 1 in your denominator. It's automatic 0. If you meet 2 of the 3 of these data elements, again, it's a 0 out of 1. If you meet all 3, that's 3 out of 3, so you actually get a 1 out of 1 for your numerator and your denominator, giving you 100%. So I just want to share that. So it's kind of, when you focus on any individual ED transfer measure, you actually have to look at all the data elements, and that's kind of where the PDSA comes in, which we'll talk in more detail later on down the line. But you want to pinpoint whether it's all or nothing, and that's why I'm asking this question. And it looks like we have the answer. It looks like the majority is medication history, seems to be the one that everybody feels that their facility struggles with the most, which is interesting because that's kind of what I was wondering. That's kind of what I was thinking, and in some of the research materials I was looking at, that seemed to be the consensus as well. Looks like medications given in ED might have been a problem for a facility or 2 as well. So I thank you guys for participating in these polls because they're going to help me in knowing what type of materials and education to share with you in the future as a follow-up. Oh, and I'm noticing some stuff go on in the chat. I just want to mention the PowerPoint slides. They did not go out like they did last month prior to the presentation. I literally made some changes up until today's webinar. Not sure if the polling was going to work. So the moment the webinar is over, the PowerPoint presentations will be sent out to everybody. I apologize for not getting out a couple days before the presentation actually took place. But it will be sent out after the call's over. Let's see here. Okay, so we're going to move into the ED transfer ED transfer Measure-4. I want to just touch on this again, give you a visual of it. You'll see right here on the screen, this is the main information that comes out of the specification manual for the ED transfer project itself. This is all on ED Measure-4. You can see right here where I have highlighted, those are the 3 components or data elements that are looked at. Like I mentioned earlier, it's an all or nothing. And if you miss one, you miss it all, you miss the entire measure. You got to get all 3 of them in order to be successful at passing this actual measure. And I'm going to actually go into, let's see if I can bring it up. Does anybody actually have any questions about how those are all related, or how they actually are, the data elements are tied as to ED transfer Measure-4? I mean, okay, I kind of figured. So real fast, like the key component across all 3 of these data elements, whether it's medications administered in the ED, the medication history, and the allergies, the main key verbiage across all of them is that you have to indicate that the information went with the patient or was communicated via fax or phone or internet or EHR as we're implementing those EHRs within 60 minutes of the patient's discharge. Now I know a lot, excuse me, with the ED transfer component, it's on your end. It's making sure all the documentation, it's not care transitions necessarily. Obviously, it's the first step to it. but it's making sure, for the purpose of this project, it's making sure everything is done on your end, documented on your end, to ensure a successful transfer. So there's no necessarily, conferring with, you could take it another step further when you implement, if you do a PDSA or if you implement a new transfer form or something like that. Like take it a step further to the facility that you transfer the most to and follow up with them to find out, okay, what can we do to improve better with the communication and the handoff and so forth. But ideally, the purpose of this project for Flex is making sure the documentation and everything is done on your end to ensure a successful transfer. And again, so one question I have, because of, like Wyoming, for example, being a rural frontier state and not knowing the other states as well, is that 60 minutes seem to be a driving factor in not necessarily meeting these measures for any of the facilities that are on the line? Does the 60 minutes seem doable, or does it seem like not doable? Does anybody have any comments on that?
Hi, this is Laura from John C. Fremont Hospital. The challenge for us in the beginning was getting them, because sometimes we're doing this later, of course, is getting the fax face sheet that shows that it's been sent and what time it was sent. Getting that confirmation sheet attached to the record was the challenge on the few cases we needed them. So we just had to keep doing education with the ER staff. They didn't see why they needed to include that in the record. So we got in. HIM was involved to validate the rules. We've had to do this a few times because people forget that we need the validation sheet for the fax. So if something was faxed later, we can see it's within the 60 minutes. That was what our solution was.
That's very helpful. Thank you for sharing. So it came down to staff education of the systems that you had in place to show proof of documentation of this, like such as the fax cover sheet that they needed to remember to print off and put in with the chart or with the patient's information to show that it was done, like date stamped, time stamped, that it was done within that 60 minutes.
Correct. And being the thrifty staff, that we all are, they didn't see any point in crowding up our server with excess paper. So they weren't including it. And a lot of people got frustrated and stopped asking them because they're like, it never happened. But once, you get a project going and there's a good reason for it and you get IT involved and assure them it's okay to use that server space, and you get HIM involved about the rules of electronic, of records, what has to be there. And once the nurses understood the reason behind it, then they were more compliant.
Thank you very much for sharing. Does anybody else have any other comments or information they want to share? Okay. We will move forward then. So again, I'm just going to kind of skim over these because the main thing, like I said, I wanted to point out just for the data elements were the allergies and the reactions as far as medications given in the ED and the medication history and so on and so forth, was the fact that they all have you have to indicate the information, what information went with the patient or was communicated to the receiving facility, via one method or another within the 60 minutes. That is obviously the key thing right there within the 60 minutes. And, of course, making sure that it's documented. There were a couple of things that I wanted to share. Let's see. Because especially when dealing with the medication information, and I don't know, and then I don't want to get into this or open up a can of worms, but the one thing to be thinking about when doing at least quality improvement on this area of the ED transfer Measure-4, focusing on your medications, is it ties really well into MedRec, the medication reconciliation, especially at discharge. So because you're transferring. So it's just something to keep in the back of your head when you're doing improvement in this area, is seeing how nicely those pieces fit together. Like I said, I don't want to get into that right now because obviously we need to focus on the measures. But let's see here. There was something that I was going to pull up. Let me see here in my notes. Bear with me one second. Let's see if it'll change to the next one. It's kind of frozen. Okay, so this kind of goes into what's been being shared. It comes down to communication and documentation. Of course, those 3 data elements, every single one of them, like mentioned, has to be done within 60 minutes, and it has to be documented, and it has to be communicated in some form or another that it was shared or it went with the patient via, fax, EHR. So the main points that I want to make is that it's important to encourage healthcare professionals to take personal responsibility for the transfer of information about medicines. So depending on how it is in your facility, every facility has a transfer policy or procedure that they follow, and there's always going to be those key players that are responsible for the transfer. Everybody has their own role, and I'm going to kind of get into that in the next couple of slides. But when it comes to this measure, having a common data set for improvement and development of your organizational system and process to support the safe transfer of information about your patient's medicine is key. So whatever system and or process you have in place, it's going to be, obviously, that's what's going to be looked at. That's what you're going to use the PDSA for. That's what you're going to use the data for as we get further down in the presentation, for you to see what is broken or what's falling through the cracks. So the other thing, of course, that we're hearing, especially with like Partnership for Patients and patient and family engagement, is you hear it over and over again. It's important to engage with the patients and encourage them to take an active role in understanding their medicine to improve their safe management when they move between care providers or healthcare settings in general. I can't tell you how many times that I've gone in and had to give my medications, and I forget just the little random things that I have at home, like or any herbal medicines that you might be taking. I mean, it's just little things like that, but they constantly are stressing getting patients more engaged and encourage them to take an active role in their health care. So I just wanted to pop that in there. But and then this is my favorite slide right here. For all of those of you who know who George Bernard Shaw is, one of my favorite quotes is, "The single biggest problem in communication is the illusion that it has taken place." Or the fact that you know that it took place, but you didn't document it, so you can't prove that it took place. Let's see. Sorry, the slides, for some reason with the polling in there, they're being a little, they're freezing up on me just a little bit. Okay, so we're going to go into like some more information about communication and documentation when it comes to like the 4 core principles for healthcare professionals, and then some key roles and responsibility, and how everybody plays a part in the transfer, and kind of just general overview of who does what kind of from a national standpoint. But again, with each individual facility, depending on who does what and how many different hats you wear, especially for small critical access hospitals, of course, you will be modifying and or doing it for what works best with your facility. So healthcare professionals transferring a patient should ensure that all necessary information about the patient's medicines are accurately recorded and transferred with the patient, and that are responsible for ongoing prescribing is clear. So and we're going to get into like the actual forms and stuff like that. So when taking over the care of a patient, the healthcare professional responsible should check that information off about the patient's medicines, and that it was accurately received and recorded and acted upon, and so on and so forth. So this is like both on the receiving end and on your sending end. So it's kind of like a dual here with the care transitions. It's kind of hard to just have, without having those two components interact at least some point during the QI process of when dealing with these measures, because it's the next step, I should say, with the continuum of care, or the care transitions, whichever word you prefer. Anyways, again, this gets into patients and their caregivers or advocates or parents or whomever is responsible for that patient, and encouraging them to be an active partner in managing their care, particularly their medications, documenting them. The information about patient medicine should be communicated in a way which is timely, clear, legible, and generated and or transferred electronically. Well, that's obviously electronically is put in there because of everybody in their process and or steps with the EHR. So again, I mean, I don't really know of any other way that people are sharing this information other than electronically. I mean, does anybody on the line still do it via paper, or does it go with the patient in like a transfer form, like hard copy information, versus it going electronically, like whether it's fax or EHR or anything like that? I mean,
this is Laura.
It would be interesting. I'm sorry?
This is Laura at John C. Fremont. We do a lot of EHR, but everything is like printed and sent with the patient. We do not electronically transfer it.
So it's like so everything on your end is electronic, but then when it's transferred, it's printed and the copy goes with the patient?
Yes.
Oh, okay, awesome, okay.
And we have a wonderful triplicate form that has check boxes. That's sort of like a thinking pathway, and everything's put on there. It helps us keep compliant with everything, and that's, I think, why we score well on most of these, is because they make sure everything's included.
So it's like a checklist that the staff go over to make sure everything is printed and goes and in like a packet that goes with the patient?
Right, and it's actually a form that says when the physician contacted the other facility and all this other stuff. So it just makes doing this whole job much easier.
Yeah.
We've had that in place for ever since I've been here 19 years, and it's always been used.
And is that form that that form that you're talking about, that checklist, is that in your EHR, or is that like also like a hard copy of that?
It's actually a double or triplicate copy. It's not in the EHR, but we do have a nice little summary we can print now from the EHR. But we still need nurses' notes and physician notes, and is the PCR available, and all those little things, X-rays, labs. And it just makes things so much easier. I've been here, as I said, 19 years, and we've always used it. It's been updated a few times. I'd like to update it with a couple more boxes, but, we're doing pretty good right now. So,
would that be something that you would be willing to possibly, I mean, I don't know. I know you said it's like a 3-page, but would that be something you're supposed to? Ooh, yeah. Would you be willing to scan it and share?
Yeah. Sure.
And when I have, Rochelle Spinarski is the one who sent out the appointment for this webinar, and I have her attendee list. So when the call's over, I'm going to follow up using her distribution list to send out the copy of the slides. So my contact information and or email address will be in there, but it'll be at the end of the slides too. But if you wouldn't mind scanning and sharing that, then I can send that out to the group as a shared tool. That would be awesome.
Right. And a few times things are written in, like it's a great spot for the nurse if she forgot to put in her EHR, spoke to this nurse at the other facility, and gave a report and all this stuff. They last minute, they'll very occasionally will write it on that form. It's like our last communication form. So if they forgot, they don't have to go back in EHR and print everything. They just shove it on that form, and it's been very wonderful.
I would love to see it. It sounds like it's working really great for you guys.
Yeah.
Does anybody else have any other a form or a process or system that's working for them that they would like to talk about or share as well? Okay. So just moving on, the 3 key responsibilities for organizations providing care. I know a lot of this is standard and to most of you, or very familiar to most of you, but it's nice to have a little bit of reiteration of it as it springboards into other components. So obviously each facility is responsible for ensuring that they have safe systems in place, that they have defined roles and responsibilities within their hospital to ensure that that healthcare professionals are supported during a transfer and supported to transfer information about patients, specifically obviously in this case medication information and to do it accurately. Your system should focus on improving patient safety and overall patient outcomes, obviously, because ensuring allergies, medications given in the ED, and or medications at home, or I should say appropriate and accurate documentation of a patient's medication history, all, like I said, tie into med reconciliation, but also, like we're talking about adverse drug events, but it ties into you never know, like with drug interactions, overdoses, that type of information. So, I mean, all of this, ED Measure-4 is like one of my favorite ED transfer measures, just because there are so many different components that touch the medication information that you have a chance to see how it impacts each area, like the med reconciliation and your adverse drug events and med errors and stuff like that. So good and poor practice in the transfer of medicine should be shared to improve systems and encourage a safety culture overall. I don't know how many of you are very familiar with ARC's patient safety culture, but again, this is like another component that ties into that as well. Handoffs and transfers. But the reason why I'm touching on all this, because it springboards into the fact that everybody, again, like I said, this is going to change and vary depending on, depending on your facility, how many hats you wear, who's responsible for doing what works best in your ED. But everybody plays a role in the transfer of a patient. It's the physician's responsibility to complete the transfer orders, including the medications according to your facility's medication reconciliation process. The nurse has a responsibility to discuss new medications ordered with the patient and the family, arrange to have medications prescriptions filled, so on and so forth, and or I should say communicate that with the receiving facility, complete any required teaching for continued treatments and medications if they're going home, and document on the discharge instruction form, ensure medication reconciliation is complete. So this is kind of where it ties into the MedRec, which I just want to touch on. I don't want to get into, but just kind of give you a visual of how it can all tie together. And then, of course, again, there's a little bit of patient responsibility in the fact that they need to understand their medications, like what are they taking, how often are they taking, what are they taking at home. And as we get into forms and stuff down the line, there a couple facilities shared with me who have like clinics that they work with or that they're associated with, and or the nursing home or long-term care facilities that they're connected to in some of these rural facilities. They have some forms that they use to help keep track of residents' medications or whatever when at home and stuff like that, and or they share like a packet they share with the caregiver or family member to help keep track of all the medications and what they're taking and stuff like that. Not to get off on a rant, but you'd be surprised how like a little simple form would help. I have, my father is diabetic, and he has, on top of his diabetes, he has multiple health issues. And he's on blood thinners and blood pressure, anything you possibly imagine. And honestly, just me being in like the healthcare, I'm not a nurse, but I'm a healthcare statistician, but just knowing and being involved in healthcare for the last 12 years, you would think that it would be common sense to me. It's not. So, I mean, he's just on so many different meds and so many different dosages, and his long-term, his short-term insulin. You'd be surprised how like a piece of paper that is structured in a way that is easy to fill out and keep track of all of his meds and what his dosages are, how handy and helpful that is, especially when they are getting to an age where somebody in their family has to take over and or help them. So it's just like there's all these little components that meet together. And I'm going to get into the medication history here in a minute. But anyways, so the forms, I know everybody talks about paperwork and more forms and more things to fill out, but if they interact very well with each other and they work, or if they don't work, especially if they don't work, if they work, I mean, they're like literally like they can be lifesavers. If they don't work, then that's what the PDSA comes into. That's what your small little quality improvement activities come into play, is we have a form, is it working? Yes, but we're missing a piece. That's what this is about. That's what the small quality improvement and PDSAs are about. So before we continue, there's going to be another survey that's going to come up on your screen, and I hope you all can see it. The one thing that I want to ask is and we kind of already touched on this, but it'll just be nice to keep it fresh for my memory purposes going forward. Out of the 3 data elements for the ED Measure-4 that we have gone over, sorry, it kind of cut it off, whether your facility struggles with one or all of the data elements, so earlier we found out that it's medication history. So out of the medication history, let's say, because now that I can't reword this, but what do you think the primary issue is as to why you guys missed medication history, let's say? Or what is the primary reason that you feel you missed allergies and reaction? Is it a documentation issue? Is it a staff education issue? Is it that you don't have all the information you think you need on your form or in the chart to be able to document or prove that that information was done or collected? Or is it all other, like we didn't even reach on it today at all or even briefly talk about it? I'm just curious if it's going to be a documentation issue, a staff education issue, a form issue, or I don't know if you guys can see my emails popping up. I should probably close out on my email so you guys can't see that. Okay, so we're going to take a couple minutes. Okay, it looks like quite a few people are responding. I think you guys can actually see the responses. I think I allowed you guys to view them.
You can see it, yeah.
I apologize if the question got cut off. Like I said, you guys are my guinea pigs. So yeah, but that's pretty much what I got a little wordy here. But yeah, what I'm pretty much wondering is whether you guys struggle with one or all 3 of the data elements. Why do you think that is? Is it documentation, staff education, have to do with your form or your chart, or is it other? Okay, and it looks like I'm going to close the poll. Haha, here we go. So it looks like primarily it's a documentation issue. For those of you who are on the line who have and would not mind sharing, those who selected the form or chart issue, would any of you care to elaborate on that a little bit? Like why you think, whether you're struggling with one or all of the 3 data elements under the ED4 measure, why you think it's a form or chart issue, like what you mean specifically by that? Okay. Well, that's fine. So that's why we do surveys. They're anonymous. But, I'm just kind of curious. To me, when I put that in there, what I was thinking when plugging the form or chart issue in there is we've had a couple ladies today share that either one, they're having problems with getting the information in or out of their EHR, or they have a form that's been working and it's continually worked and they just continually update it as they need to as things change and it's what's working for them. So for me, when I put the form and chart issue in there, what I was thinking is that you guys don't, that for that, if a facility selected that they don't necessarily have a form or system in their EHR or checklist or transfer form or whatever currently implemented that's effective, or they haven't got that far yet. So to me, that's what that option meant. So, and then of course staff education. We had another gal who was kind enough to share about the fact that hey, they have a system in place, they have a process in place. It's just a matter of educating the staff that hey, when this information is sent, you need to print the fax cover sheet with the date and time stamp and put it in with the chart, because it proves that one, hey, this information was communicated, and 2, it was done within the 60 minutes. So, and boom, just knowing the staff, once you have a system in place, educating the staff on how to use it and ensure that's being used effectively and properly, that's why you're going to be consistently do well across all of your measures, or the measures that you are focused on. Let me just go on to, oh, come on, it's frozen again. Okay, so I'm so glad, well, I shouldn't say I'm glad, but when we were doing the survey questions earlier, it seems like medication history was the primary reason out of the 3 data elements that people were saying their facility was struggling with the most. I'm hoping maybe we can get a couple of you to say why you think that is. But the one of the things that it's not, you're not alone. It seems like nationally that tends to be the main area of focus where taking the medication, I should say, the medication history is the issue. Whether it be taking a good medication history or actually documenting a good medication history, or ensuring that all of that information is actually being transferred and or shared. The timing, they didn't really talk a whole lot about that in the comparative information that was shared, the national data results that I looked at. But those were, essentially, those were the main reasons. Is one, getting a good medication history, documenting it, and then ensuring that it's shared with the transferring facility. So what I'm just going to touch on is some tips that they shared about taking medication history, and I'm hoping that some of it will be helpful to you, or at least one component of it will be helpful to you, or it'll give you some ideas. The primary thing is obviously using a systematic approach. Ask about prescription medications, over-the-counter products, vitamins, herbals, nutritional supplements, and then, of course, from that, develop and implement a standardized process of work, like a workflow, on how to take a medication history and how and what questions to ask. Anyways, the other thing, of course, that we're going to come back to is engaging the patient. How it's important that they get involved in their health care, curating an updated medication list to share with their healthcare providers. I know that's really helpful, and that would be wonderful in an ideal world. But I know that's not always the case. Me, again, just to kind of throw myself under the bus, I'm terrible. Like, I go in and I cannot even begin to tell you how many times when they ask me, like, what am I taking at home, that I say nothing and don't even think about, oh, okay, well, yeah, I do take B12 or I do take vitamin D, or, it's just, I understand that stuff's not necessarily life-threatening, but I'm not a pharmacist, so how do I know what's not going to interact with something else? And then, of course, as we get older, going back to my father, he is in the state where he can remember the stuff, but when it comes to the point where, his memory might be failing, I'm not going to be able to remember that all as his daughter. So having a medication list, I think, to share and keep educating our patients, I think is helpful. They did stress patient engagement a lot in the national forum results for ED transfer. Well, I should say medication history. Anyways, and I think it helps, like for me, especially being a patient, to know the importance of it from a clinical standpoint, like of obtaining a complete and accurate medication history. Comes back to me saying, hey, I don't know, like I don't even think about my vitamins or the Tylenol that I take over the counter interacting with anything. But like I said, I'm not a pharmacist. How am I going to know? So if, maybe having that one-on-one interaction with your patient and the importance of it, and I think it might make it more understandable or trigger more. And this kind of ties into the next tip. Avoid yes or no questions. Ask open-ended questions because it helps solicit additional information, and I think that's huge for me as a patient. If they just ask, do you take any medications at home, yes or no, I'm not going to actually think about it. But then if I think, if they ask me any open-ended questions that might lead into, oh, yeah, I am taking vitamin D, or oh, yeah, I did take vitamin B12, or oh, yeah, you never know. Everybody's different, but review medical history, inquire about commonly prescribed medications for healthcare conditions that are listed within the patient's chart and or documented within the patient's chart. Let's see, come on, change. And then, of course, some things to keep in mind is consider all the sources when obtaining medication history, and also to clarify any conflicting information. So obviously you want to talk to the patient. You want to look at their medication list. When was it last updated? How often do they update it? Do they maintain it? If they have a caregiver or family member that's helping them, check with them. They might have forgotten, the patient might have forgot something that they're taking. Who their primary health care or prior health care provider was, what they were on, who their pharmacist is, who they go through. That might be helpful. past medical records, again, that kind of ties in with their prior primary care provider. And then, of course, there are things, just common to everybody, remembering that for each medication, the name, strength, dose, route, frequency, and all that stuff like that. And then note any discrepancies in prescribed medications versus what the patient reports he or she is actually taking. But not to kind of, I see that we're getting down to the hour, and we do have extra time. We're, instead of doing these webinars for an hour, we're going to do like an hour and 15, because I didn't want to like cram everything in to an hour. So I'm just going to kind of flow through these next couple of slides because I want to get to some primary stuff here. But here's just some sample questions on what to ask to help with medication histories, about like what kind of questions to ask about allergies, common health conditions and ailments, over-the-counter meds, prescriptions, herbal natural supplements, any kind of medication concerns. Those are like the open-ended questions. Like if you get somebody talking about any kind of medical concerns they have about themselves, it might lead them into talking about medications that they didn't necessarily think they were taking that they have taken. So those are just in there as like a reference to help with medication history. I mean, I'm sure most of you are familiar with at least some of them, but the main thing I want to get into right now is, okay, the ED transfer report, which I did go over in the last webinar on ED transfer 6, but so I'm just going to bring up the report that all of you will see when you're collecting and reporting your data every quarter to your Flex coordinator. You can run this report, and this is kind of just a screenshot of what the top portion of the report looks like. And I'm going to go to, this is the bottom portion of the report. I wanted to be able, for you guys to be able to see it, so I had to cut it in half. And you will notice here at the very top of this slide, here's your ED transfer 4 medication information. And again, you will see here, so I entered in 5 mock patients, and I decided to pinpoint that the medications given in ED we did really good at, and then of course allergies, reactions, medication history we did not do so well at. So allergies and reactions we only met 1 out of 5, and medication history we did 2 out of 5. But the reason why I did that is I want you to look at the percentage. This gets into what I was saying, the all or nothing. Whereas, see how we did 100%, 5 out of 5 patients, we did great at the medications given in the ED. Back to the allergies and reactions, we only met that for 1 out of 5 patients. Medication history only met 2 out of 5 patients. But then look, overall, how did I do for ED measure 4? 20%. I met one measure. I met all measures for 1 patient. That's it. So I got a 20%. So that's what I'm talking about, the all or nothing. You need to have every single one of these data elements, all 3 of these need to be completed, documented, and accurate for each patient in order for you to sustain that 100% or that 80% or that 90% or whatever. And that's how actually, and you'll learn going forward as we move forward with the other measures when we go on to ED Measure 5 in the next couple weeks. Same thing. All these data elements, and then back to the ED Transfer 6, you'll see here we went, last month we went over all 6 of these data elements. Again, it was getting all 6 of those to stay consistent to be at 100%. Now, if like oral restrictions, we would have been at 20%, then the data element itself for ED Measure 6 would have been at 20%, even if everything else was 100. So that's how these ED measures, ED transfer measures are set up or I should say analyzed and calculated. It's the all or nothing. So the great thing about this report and that how it's broken down is that each one of you now can go in to your ED transfer report. You can go to ED transfer measure 4 or whatever measure, whether it was 6 from last month or in the next couple of weeks we're going to be going over ED measure 5. You can pinpoint which area, whether it's one of these areas or if it's 2 or 3 or it's all or nothing, or which area you're lacking at. Like when we did the polling, obviously the majority said medication history seemed to be their biggest problem. Okay, now we have something to go off of. Now we can go back, and you being critical access hospitals, I understand some are larger than others, but this is where it comes into validation. Re-abstract, pulling a random sample of those charts. Well, for me, I would only have to go and pull 5 charts. For this sample here, I would go pull my 5 charts, I would go into each chart and I would find out, okay, what the heck are we doing under medication history or allergy reactions? What are we missing? Why did I get it from one patient, but the other 4 patients I didn't? And that's where you can pinpoint your PDSA project, your small little quality improvement, rapid cycle improvement activity. This is what, I mean, obviously for those of you who have 20 or 30 patients in a quarter because you're a larger critical access hospital, you could do a random sample. Or in some cases, you could just look here and say, okay, we had 20 patients, but 10 of the 20 patients we missed for medication history. Okay, we'll go pull those 10 charts. And you can pinpoint knowing what those 10 charts are is if you actually leave this report screen, you can go back to your record list right here, which this is a screenshot so I can actually physically do it. But you can go back to your record list and you can actually see the charts that were entered. And you can look at that time period. And that's how you can actually pinpoint which charts to pull so you're not just randomly pulling some. But regardless of how many patients you had for the quarter, whether you do a random sample or you pull them all, you can see what you did right in some where you got 100% versus why you didn't get 100% in the others. And that's where you can focus your energy as to, okay, is it a staff education? Because, hey, we do have this system in place. They're just not printing a fact sheet and putting it in with a chart to prove that that information was communicated with a timestamp, you know? Or, hey, we're missing allergies and reactions on our form. That's not being communicated. Hey, we need to update our transfer form to include the allergies and reactions. And then it's just a matter of educating staff. Hey, we added this box. You guys need to start checking it, timing or dating it, and initialing it. You know, that's where you focus your PDSA. That's what the PDSAs are for, and that's where you can pinpoint and focus your quality improvement efforts. Let's see here. I want to get so we had a best practice high performer who shared some information with me because they weren't necessarily doing well in some areas and not well in others. It was more of, hey, they were doing great across all the measures. So it was really hard for her to be able to pinpoint it and make it specific to the ED Measure-4. So she was able just to share some stuff with me, and I hope that I'm able to cover it as good as she would have been able to. But some key things that she just said that works for them is that they have transitions of care principles and standards like within their facility. Let me see. She said, make sure that your hospital has policies and practices that incorporate the principles of care or transitions of care, whether, you know, she says there's so many different ones out there, but she says initially they consist of accountability, responsibility, coordination of care, family involvement, communication, timeliness, and then, of course, comparing that and using the national standards and metrics to establish that. But just to kind of go over the bullets that are up on the slide, she said with improved accountability, she said all of their transitions must include records that contain core elements of their care transitions, which is what they and their team have developed, what those core elements would be. And then, of course, she said any additional elements should also be included as it's appropriate for each patient. So whatever is specific to that patient that might fall outside the norm, they also include. She said identify responsibility. She's like at every point during their care transition, the patient and their families and the staff who are handling the transfer must know who's responsible for the care and how to contact you know, the caregiver or the receiving facility or the transferring facility in case of an emergency and so on and so forth. She said the transition responsibility belongs to the sending facility, the clinician, so that would be like the physician, the nurse, and stuff like that, and the organization, the hospital as a whole, until the receiving facility confirms assumption of the responsibility. Coordination of care, she talks about just how whoever is involved, and it goes back to identifying the responsibility. She said whoever is identified as the responsible parties within the transfer must provide timely communication to the receiving facility and to everybody involved in the transfer. She talks about how they believe strongly in involving the family in terms of what she had worded was patients and families must be involved in and retain ownership of transition records, including information needed to identify patients' medical care home needs and any coordinating physician care. So then she talks about, clearly communicating, which means she's like just how many times it's hard to read somebody's handwriting if it's not electronic, if it's a printed version or if somebody's writing something. She said how it believe it or not, illegible handwriting can be very frustrating. So she said must provide a clear and direct communication infrastructure, including transition records, treatment plans, follow-up expectations, and so on and so forth. Assure timeliness. Again, it comes back to the team must provide information, feedback, and feed forward based on transition settings, patient circumstances, level of acuity, and transition responsibility. And then it gets into the national standards and metrics. She said, standard communication formats for care transitions they have adopted and implemented and used for accountability and continuous quality improvement in their facility. And they have standardized methods of measuring outcomes and how important those are to a facility and that they should be implemented across healthcare settings. So they do have a facility that they said they started to work with one step further through like a care transition. And this facility, I should say, they participate in the ED Transfer Communication Project, but they have also participated in care transitions. So that's the national standards and whatnot they're very familiar with because they work with the facility that the acute care facility they transfer primarily to on a lot of this information. I think she said that's why they were able to ensure not only that the documentation was correct on their end through the ED Transfer project, but then it was great to be a part of care transitions with the acute care facility as a project to ensure that, okay, yeah, everything on our end documentation-wise being done, but okay, is it actually getting there? And if so, how? So let's see here. We're having a couple minutes after, so I want to kind of just, this is one of the forms she shared, and I apologize because I had to take screenshots of it because it was so kind of blurry, and I really apologize. This is a national one she said that they adopted, and she said they have made some changes. This is kind of a little bit older, but this kind of includes everything that they have with the transfer of the patient. They call it their standardized patient transfer form, I think is the verbiage she used. Anyways, so this here you'll see has all of the information, and actually it's 2 slides because again I apologize, I had to I had to break it up so that you guys could actually see it. Okay, here's the second portion of the patient transfer form that was shared. And I want to open it up. I know a couple people have already dropped off, and I don't want to lose you guys because I want to ask a couple more survey questions. So this leads me to sharing that transfer form and talking about the checklist. Some of the facilities sharing that they have a checklist or they have a transfer form and that they're going to actually share some of that information with us that I will make sure to send to the group. I would like you guys to take the time to answer this yes or no. Do you guys have a checklist or a transfer form that includes all 3 data elements for the ED Measure-4 to ensure that all are completed? Yes or no? And because this is going to be helpful because if the majority of the questions are no, then that means, hey, we need to reach out. This is something that we can do to help you guys. We can reach out to some of the top performing facilities and be like, hey, will you share your checklist, or hey, will you share your transfer form? And then that's something that we can work together across our 3 states to send out to all of you who are participating and also those who weren't able to make the call, but send all to all you critical access hospitals to share. And it looks like, okay, I'm going to leave it open for a few more minutes, but it looks like a lot of the people do not have a checklist or a transfer form that actually includes all 3 data elements of the ED Measure-4 to ensure that they are completed. Okay, here, I'm going to close the poll because it doesn't look like anybody's doing it. And in the essence, the responses stopped coming in, so I'm just going to close it. So 70% of those of you who are still on the line, it looks like you do not have a form. That is very helpful information. So when we send out the slides, we are going to send any transfer forms that I have or that have been shared, like the high performer, like on the previous couple slides. I will share checklists, transfer forms, and the PowerPoint slides. So those will go to all of you. And then as I follow up with the ladies who have shared on today's presentation, the information they have, those will go out additionally down once I get those. And hopefully within the next week or whatever, we'll send those out as well. So let's just move on real fast. I'm loving these polling questions. You guys are awesome at participating in them, so thank you. This is very, very helpful information for us. So I know a lot of you being in healthcare are probably familiar with PDSA or PDCA, depending on where you went to school. Plan, Do, Study, or Act, or Plan, Do, Check, Act. This leads back to the report that I was showing you for first quarter, looking at the 3 data elements, identifying if it's 1, 2, or all 3 of them, and then implementing a little PDSA. Using that report and implementing a PDSA is knowing why you need to improve a system in or process. And by looking at your reports, you will be able to pinpoint the area right away. That's what's great about the ED transfer tool. And then you have to have a way to obtain feedback to let you know if the improvement is occurring. So, for example, if you notice that medication history is, when you pull your charts, is going to be the main concern of your facility, it's the one that you're constantly missing, go and talk to the nurses and find out, okay, what's happening? Why is this not being documented? Or is it a matter of a form? Is it a matter of staff education? That's what you need to do. After you identify and pull the charts, find out what element you're missing and where at in the chart, like what are you doing right, what are you doing wrong. Then you need to get feedback from the staff who are actually doing the documentation to find out, to get feedback, find out what's going on. Not only just to see if improvement is occurring, but to find out what's going on and to see if they have any suggestions on what you can improve or what's being complicated, why it's not getting done. Because they're the ones who are in the charts. They're the ones who are trying to document the information. They're the ones who are trying to pull the information. And then, of course, develop a change that you think will result in improvement. So after you gather all that feedback and you hear from the staff and okay, it's medication history. The staff say it's not, the EHR is not user-friendly, we don't know how to do it. Then it's a matter of staff education. Or whatever you pinpoint, or hey, we're missing a form or whatnot. Then you need to implement a change, whether it's adding a couple of components to your transfer form, adding a couple of components to your checklist because it's not, you guys are missing medication history or you're missing allergies and reactions. Then after you implement that, you need to educate the staff that you've implemented that change. Then when you submit your next quarter worth of data, you need to go back and you need to remeasure it. You need to look at, okay, has our data gone up? Has it gone down? Is it staying the same? And then from that, it's continuous improvement. Keep fine-tuning it to find out, okay, what are we going to do to be able to get this at 100%? So I just had encouraged a couple of slides because I know not everybody has it. If my slide deck would change. Not everybody's familiar. So the main key thing is, what are you trying to accomplish? Well, for us today, it's improving ED Measure-4. And how will we know that change is an improvement? Well, because we're going to monitor our data every quarter when we submit it to our Flex Coordinator. So right now you have several quarters worth to go off of worth of data to see where you guys are sitting at. And then come the end of July is when your second quarter is due. So there's no reason why you can't look at just this small little area, see how you guys are doing, and implement a change, and then remeasure it. Obviously we're in June, but you get the point. Is that you can implement a small little change, monitor it, and within the next quarter know how you're doing. And then what change can you make that will result in improvement? Well, that's, again, when it comes down to pulling those charts like I was saying earlier. Once you have identified which measure or data element of ED Measure-4 you are not doing well on, and you have pulled a sample of charts, and you have identified what you're doing wrong, you need to implement, like I said, transfer forms, staff education, like the one gal shared, hey, they had a process in place. It was just staff education on printing that fact sheet out. Or, some staff are saying, hey, we have a form, it's just educating them, we need to update a couple of components. Or hey, we have it in the EHR, it's just that we're not getting along with the EHR right now because I know everybody's having headaches with those. So it could be staff education on how to better use the EHR. Or it could be, hey, our EHR isn't including all this, or it's not user-friendly, so let's work together to try and make it more user-friendly and easier for staff to document that. Make me anything. And then the next slide is just more of a description on each component of the Plan-Do Stay Act. The one thing that I really wish we could do hands-on on these webinars, which we can't, is actually pulling a chart, looking at a chart, finding out what's wrong, because it's going to vary by facility. So I can't physically hands-on do that with you. That's going to be up to you guys as homework to do from these calls, is to go and look at your report, pull some of your charts, find out what's going wrong, get feedback from the staff, implement something that you think is going to be effective to improve your rates. And then next quarter when you submit data, revisit the data and see if there's been an improvement. So let me just skip ahead here because I know we're running out of time. While I'm skipping ahead, does anybody have any questions or comments? I'm just going to, the lines are off mute. I didn't mute them. So while I'm skipping ahead, oops, here we go. And again, I will include these transfer sheets. So these are medication transfer sheets that facilities shared. Again, these are the ones where facilities were actually working with their long-term care nursing facility or their physician office that they're associated with in their communities, and to help engage patient education. Here, for example, here's a medication form. This is something that they share with their patient to ensure that they have everything documented, like the name of their medication, the strength, how and when it's used, that thing, and to encourage them to take it every time they have a doctor's appointment. But then there are other ones. Let me just skip real fast. Like, here is a patient medication vitamin supplement log. So these are some of the tools that are being used by some of the facilities to help with the medication history, at least from the patient engagement standpoint. And then the patient's encouraged to bring it in, then they make a copy of it, they kind of sign and date it so they can keep track of the medical record when the last time they received this from the patient, when it was updated, kind of stay on top of it in case like the patient doesn't necessarily remember because they might have so many. But anyways, so this is just a couple of the forms that some of the facilities shared with me about that they were using, at least in helping them with their medication history. And then let's see. We went over these on the last webinar. They are sample checklists and sample forms, which I'm going to send because it looks like we had a lot more people attend and participate in this webinar. And based on the polling results, it sounds like there are quite a few that want some checklists and some forms. So I'm actually going to attach all of these. There are just 3 checklists and there are 3 transfer forms that were nationally ranked as I don't know, like the top ones that facilities like. They were just nationally ranked as the best ones that encompassed everything for a successful ED transfer that had all of the data elements, all of the components. So I'm just going to attach those to the email when I send out the PowerPoint presentation, because if it would stop freezing, I did try and include screenshots of some of them. If we had time, I was going to go through them. But I'll just kind of show you them briefly. And then, of course, so here comes the transfer forms. And of course, these national ones that I'm actually going to share that I'll send out with you, you can change and modify to fit your needs. So, like obviously, if you see them and they have everything, but you want them to include additional things that are specific to your facility, that's what they're for. They're to adapt and tweak and meet your facility's needs. With that being said, I'm showing we have 4 minutes left. So I am going to wrap up. I just had a couple of reminders that I wanted to say to everybody on the call. The second quarter 2016 ED transfer data submission deadline is July 31st. We have a quality improvement newsletter that we send out in Wyoming that's going to be going out on the 17th of this month. It just covers MEQIP topics. And then just a couple of MEQIP deadline reminders. First quarter outpatient data is going to be due August 1st. First quarter inpatient data is going to be due August 15th. And for the outpatient data, of course, that includes like the AMI, the chest pain, the pain management. and so on and so forth. And then for the inpatient core measures, the only one that's a requirement right now for MBQIP is the immunization 2 measure. So, and then as far as first quarter 2016 inpatient outpatient population and sampling, that's going to be due August 1st. And for those of you on the phone, I'm not going to get too much into this, but I do know that on upcoming webinars, we're going to touch more on the population sampling and stress the importance of it, because I know it varies by state on how the facilities are doing. But I just want to put this bug in your ear. When you are a small critical access hospital and you do not have a whole lot of measures that are eligible for inclusion every quarter, so let's say there's some quarters where you literally don't have any eligible inpatient or outpatient data to report, we have no way of knowing that. So if you just don't report anything, it looks like you didn't report, versus you tried to report, you just didn't have any eligible cases for the quarter. So that's where Pop and Stamp comes in. It's done via the KINnet website, and you just go out and you simply state what your population was for the quarter, and for in this case, for the reporting of 0, you would just enter in all zeros and submit it. Then we would know that you actually didn't have any cases to report. But we're going to get more into that, but just a heads up. So any Wyoming facilities who are on or have any questions about that, just reach out to me, and I can follow up with you on that. I want to leave this slide up on the screen. So for those gals who are on the phone that were willing to share a scanned copy of their form, here's my contact information. I'm Shanelle Van Dyke, and my email is chanelle.vandyke@qualityreportingservices.com. So anybody who has any questions about today's presentation, please feel free to email me. Any of you who want to share any of your forms or checklists that maybe didn't feel like speaking up today, or who did and want to share their information, please email me. It would be great to be able to share some of the stuff that some of you were kind enough to share with us today with the other facilities via email. And then just stay tuned, because upcoming, and I know Rochelle already sent out a reminder, but the ED Transfer 5 webinar is going to be coming up at the end of the month. And she did already send out an appointment for it. We will get the PowerPoint slides out a couple days before the presentation. Again, I apologize for this one not coming out. I was trying to do the polling, and I did make some last-minute changes. So it will be going out here today to all of you. And with that being said, I'm going to wrap up unless anybody has any questions.
Nope, just that the next webinar for number 5 is June 30th, same time, same place.
Thank you, Michelle.
And this is Jen Brooks from California. So any California hospitals that have questions, of course, you can email me at any time.
Thank you, Jen. Okay, well, everybody have a great rest of the day, and I look forward to hearing from you, and we will be in touch.
Thanks, Shanelle.
Thanks,
Thank you.
guys.
Bye.
Bye.